Hi, I'm Dr. Tom Kravis, Physician Executive for 3M Consulting Services. Thank you for joining me. Today we're going to talk about ICD-10 documentation for orthopedics. There are some changes you will need to make in your documentation to support ICD-10, but there are instances of documentation that can remain the same. So we'll reduce it down to the essentials for you, so let's get started. I know you are busy in your clinical practice, so I will briefly summarize the key takeaways. In your documentation of patient care, consider the use of adjectives. Link the cause and effect of each condition. Be specific about aspects of a disease and each anatomical site, and use exact dates when appropriate. A little more on each of these. Differentiate in your notes whether or not a condition is acute, chronic, or acute on chronic whenever appropriate. For example, acute on chronic slipped capital femoral epiphysis. Use due to or secondary to indicate cause and effect, and to record all conditions the patient may have, such as urinary calculus due to chronic idiopathic gout. Think about the most current terminology to describe a condition or different aspects of the disease. For example, Salter-Harris type 1 physeal fracture of proximal left femur. Precisely designate anatomical site, such as fracture of the greater trochanter of right femur. Ask yourself, what else could I add in my notes about this patient's condition that would better communicate how sick the patient is, which in turn better communicates the resources needed for patient care. Incorporating these aspects into your documentation will result in an accurate picture of your patient's severity of illness and risk of mortality. This in turn will result in accurate public reporting on quality and outcomes. And it will help reduce the number of queries you receive to clarify your documentation. In the upcoming slides, we'll take a look at some diseases and procedures that have new documentation requirements under ICD-10. In ICD-10, there is a feature called Laterality for right, left, and bilateral, which is found in many diagnoses and procedure codes involving paired organs, or those codes specific to one side of the body versus the other. For example, acute left otitis media. ICD-9 has a limited number of these. ICD-10 has many more. This feature of ICD-10 by itself is responsible for a substantial increase in the number of codes which you have probably heard so much about. Since you usually include this information in your patient care notes, additional documentation will typically not be needed. So for your information, if you happen to omit laterality when needed, it may result in a query. Suffice it to say, laterality is included when appropriate for some conditions you may treat, so do a quick double check of your notes to be sure you included it before signing off. We'll try not to belabor this point in the upcoming slides. As seen here, ICD-10 has 5 groups of codes for osteoarthritis. The first group, polyosteoarthritis, only requires documentation of the type, such as primary generalized polyosteoarthritis. The next 3 groups of codes are specific to the site affected, hip, knee, and the first CMC joint. Unique codes can be reported for these sites to indicate the type as primary, post-traumatic, or other secondary, and then whether the right or left or both are affected. The final group of codes classifies other types of osteoarthritis that is not polyosteoarthritis or is not of the hip, knee, or the first CMC joint. Unique codes that include laterality are provided for shoulder, elbow, wrist, hand, and ankle and foot. So think about the story your final diagnosis tells of the patient's condition. For example, osteoarthritis or post-traumatic osteoarthritis of the left wrist. Obviously, the latter tells the better story. What's new for rheumatoid arthritis? ICD-10 has 3 categories of codes which provides the ability to differentiate between 3 types: RA with and without rheumatoid factor, rheumatoid bursitis and rheumatoid nodule, and juvenile RA. Each category provides anatomical site and laterality specific codes. Additionally, RA with rheumatoid factor has unique combination codes for associated complications such as rheumatoid heart and lung disease. Obviously, this level of detail requires more of a diagnostic statement than just rheumatoid arthritis. ICD-10 provides you with the opportunity to really tell the story of a patient with a condition that can last for decades. And it is one that is easily told when your diagnostic statement identifies the type of RA your patient has, anatomical sites involved in laterality, and any associated complications. ICD-10 has 2 categories of codes for gout: acute and chronic. If you do not further describe the gout as acute or chronic, the default for coding is acute gout, so document acute or chronic to be certain your intended diagnosis is reported correctly. Within each category, unique codes describe the type and site and include laterality. Types of gout specified in ICD-10, whether acute or chronic, are idiopathic, lead-induced, drug-induced, due to renal impairment, or other secondary gout. ICD-10 instructs the coder to assign additional codes for any associated condition, for example, autonomic neuropathy, urinary tract calculus, or cardiomyopathy. Be sure to include these when known or suspected in your diagnostic statement. Note that the inclusion of tophi in your diagnostic statement has no bearing on code assignment. When the coder attempts to code gout with tophi, ICD-10 instructs the coder to see gout by type. So a diagnosis of acute tophi gouty arthropathy is still missing several crucial elements: the type, as detailed previously, for example, idiopathic or due to renal impairment, the site, and laterality. Let's tell the right story by completely describing the condition in your diagnostic statement for each patient encounter. The coding of vertebral fractures is particularly problematic for coders due to the lack of documentation regarding the cause, except in the case of obvious traumatic fractures such as a car accident. Coders understand that vertebral fractures can occur in the elderly due to a minor fall or other relatively minor circumstance that would not have caused a fracture in a normal, healthy vertebra. Consequently, when your documentation indicates a minor fall in an elderly patient who also has osteoporosis or other disease affecting the bone, the question arises as to whether this should be coded and reported as a pathologic or traumatic fracture. You should document your clinical opinion as to whether a vertebral fracture is traumatic or pathologic, and if pathologic, the type of underlying disease. Additionally, a diagnosis of compression fracture is not assumed to be either traumatic or pathologic. Your final diagnosis should state pathologic or fracture due to XYZ, if, in your opinion, osteoporosis or some other disease is the cause of the fracture. ICD-10 codes distinguish between open and closed and displaced and non-displaced fractures. In some cases, unique codes are provided for the specific part of the bone fractured. For example, greater or lesser trochanter of the head of the right femur. Fracture orientation can also be specified, such as green stick, transverse, oblique, or spiral. And of course, right versus left when applicable is also a component. So be as precise as possible when recording your diagnosis of fracture. For open fractures of the forearm, femur, and lower leg, you will also need to document type 1, 2, or 3A, 3B, or 3C according to the Gustillo classification. As you know, the Gustillo classification is used to identify the severity of soft tissue damage. Fracture healing, infection, and amputation rates correlate with the degree of soft tissue injury by Gustillo and help determine the prognosis. Physial fractures are reported based on the Salter-Harris classifications of types 1 through types 4. Finally, sacral fractures need the additional description of zone 1, 2, or 3 for vertical fractures and whether minimally or severely displaced. Transverse fractures are reported based on types 1, 2, 3, or 4. ICD-10 differentiates other injuries to the musculoskeletal system by type, such as dislocation, subluxation, sprain, laceration, and strain. In each case, additional detail should be documented for site and, in most cases, laterality. ICD-10 classifies spondylosis by type and site, similar to ICD-9. New in ICD-10 are unique codes to report anterior spinal artery and vertebral artery compression syndromes. All other types of spondylosis are differentiated by with or without myelopathy or radiculopathy. And although ICD-9 did provide for the reporting of spondylosis affecting the cervical, thoracic, or lumbosacral spinal column, ICD-10 again has more detail by providing additional codes for the occipito-atlantoaxial and sacral sites of the spinal column. This level of detail for spondylosis, which is used not only for reimbursement, but also for research and disability determinations, cannot be reported unless documented by you. ICD-10 primarily classifies disc disorders such as disc displacement and disc degeneration, as with myelopathy or radiculopathy, or both. Myelopathy and radiculopathy, indicators of the seriousness of the patient's condition and the likely increased use of resources, can now be captured. So if your patient has either, you should include it in your diagnostic statement so your patient's clinical picture is accurately reported. Disc disorders without myelopathy or radiculopathy are classified to a code that states other disc displacement or other disc degeneration. For example, code M51.26 would be reported for a diagnosis of lumbar disc displacement, but codes M51.06 and or M51.16 are reported when myelopathy and or radiculopathy is also present. ICD-10 terminology describing congestive heart failure remains essentially unchanged from ICD-9. However, there is currently an opportunity for improvement in documenting this diagnosis. To provide an accurate picture of the patient's severity of illness and risk of mortality, you should specify whether the patient's congestive heart failure is acute, chronic, acute on chronic, and whether it is systolic, diastolic, or a combination of both. Additionally, you should document the cause or etiology of the congestive heart failure when known or suspected. An example of excellent documentation would be acute systolic heart failure due to possible or suspected alcoholic cardiomyopathy. New terminology in ICD-10 provides the ability to report the type of atrial fibrillation as paroxysmal, persistent, or chronic, and atrial flutter as typical or type 1, and atypical or type 2. When you can more precisely describe these conditions, these are the terms you should document in your notes rather than just atrial fib or atrial flutter. ICD-9 did not differentiate between a diagnosis of respiratory failure and acute respiratory failure. The good news is that ICD-10 does. When appropriate, you should document respiratory failure as acute, chronic, or acute on chronic. Additionally, also specify if hypoxia or hypercapnia or both is associated with the respiratory failure. Remember, coders cannot interpret the results of tests such as arterial blood gases. They must rely on your documentation. At times, we see respiratory insufficiency and respiratory distress used interchangeably with respiratory failure. Respiratory insufficiency and distress are signs and symptoms of an underlying condition and are coded differently from respiratory failure in ICD-10. Be clear on your intended diagnosis. Severity of illness will not be reported accurately if you use one term when you mean another. Additionally, document the cause or etiology of respiratory failure, such as due to COPD, surgery, or trauma. When pulmonary insufficiency is due to surgery, documentation should describe a cause and effect relationship, and it should be further described as acute or chronic. For example, acute pulmonary insufficiency due to surgery 2 days ago. FYI, one of the differences in ICD-10 is that pulmonary insufficiency due to surgery will be classified as either due to thoracic or non-thoracic surgery. What's new here? ICD-10 has a new combination code to capture the patient who has a pulmonary embolism with acute cor pulmonale. The takeaway here is the documentation of cor pulmonale and whether it is acute or chronic. What stays the same is that you still need to document the type of pulmonary embolism, such as septic or saddle, and whether the pulmonary embolism is acute, chronic, or healed or old. History of PE can be interpreted to mean the patient has had the condition for a while, such as in history of hypertension, or interpreted to mean the patient no longer has the condition. Documentation of chronic pulmonary embolism versus healed or old PE makes a clear distinction and assures that the severity of illness of your patient is reported accurately. Severity of illness is increased when a patient has a chronic pulmonary embolism, but there is no impact on the severity of illness when the patient has a personal history of pulmonary embolism. Note that documentation of healed or old PE results in the reporting of a code for personal history of pulmonary embolism. There's nothing new with blood loss anemia in ICD-10. It is still classified as anemia due to acute or chronic blood loss. There is, however, an opportunity for improvement in documenting this diagnosis. If the anemia is due to blood loss, you need to be certain you indicate the cause and effect in your documentation. What's new here is that a diagnosis of depression without further qualification is coded to F32.9 in ICD-10, which is the code for major depressive disorder, single episode, unspecified. In ICD-9, a diagnosis of unqualified depression was assigned a code that simply said depression. If major depression is not your intended diagnosis, consider adding additional details to your documentation when known. It will change the code and better describe what you are treating. For example, major depression could be further specified as single episode or recurrent. In either case, is it mild, moderate, or severe? If severe, it is with or without psychotic features. Is your intended diagnosis something else other than major depression, such as adjustment disorder, for example, grief reaction, with depression and/or anxiety, anxiety-depression, or depressive neuroses? According to published Medicare inpatient hospital data, the code for unspecified depression appears on 1/5 of hospital records covered by Medicare. We can do a better job identifying patients with major depressive disorders as compared to those with other forms of depression that are less severe and require less resources. Given the health risks of obesity and the number of obese people, it is important for us to be able to continue to track the prevalence and cause of obesity among U.S. adults and children. Since overeating is the #1 cause of obesity, it should come as no surprise that ICD-10 has a new code for nutritional obesity, or obesity due to excess calories. So consider incorporating nutritional obesity into your vocabulary when applicable. It's a few less words than obesity due to excess calories. If your patient has morbid obesity, also document if alveolar hypoventilation is present. ICD-10 has a single combination code for this. As in ICD-9, ICD-10 continues to classify obesity due to other causes, such as due to drugs or endocrine disorders. Malnutrition is an underdocumented condition in the elderly. However, it is also an important indicator of your patient's severity of illness and an important influence on performance metrics such as readmission rates, length of stay, and quality outcomes. If your patient has malnutrition, you should document the clinical picture, the type, such as protein calorie or protein energy malnutrition, and the stage or degree. For example, mild, moderate, or severe, or first, second, and third degree. Your notes should include clinical findings such as patient with terminal cancer, 20-pound weight loss, and cachexia, and any supporting labs such as low albumin. There are no changes here. However, we mention BMI because it is used in studies to predict the likelihood of success of joint replacement surgery and how well the patient may do after surgery. When you consider BMI an important patient characteristic, including this information in your notes will increase accurate and consistent reporting. Unchanged from ICD-9 is the classification of malignancies as primary or secondary, which is a particularly problematic area of documentation for coders. Often, primary or secondary is not specified, and in the case of secondary malignancies, whether the primary site is still present. A statement of history of can be ambiguous and may prompt a query. For example, appropriate documentation of a malignancy would be metastatic cancer to right lower lobe of lung from left breast. Patient underwent mastectomy 1 year ago, and there is no evidence of recurrence. This documentation clearly identifies the primary and secondary site and states the primary site is no longer present, all of which are factors considered in code assignment. It is perfectly acceptable to state primary site unknown or to state a diagnosis as possible or probable. As physicians are increasingly held accountable for patient outcomes, A huge concern is how to classify the patient who fails to follow a recommended regimen of care and gets sicker as a result. Under ICD-9, there is only one generic code for such a patient that says non-compliance, and no additional detail as to why the patient didn't follow your instructions. But in ICD-10, there are several codes to describe why a patient is non-compliant in taking drugs prescribed by you. This new clinical terminology is drug underdosing. Underdosing identifies a situation in which your patient has taken less of a medication than prescribed by you, either unintentionally or intentionally. Document in your notes why the patient isn't taking the correct amount of their medication and the associated condition. For example, patient with history of menorrhagia was found to have unimproved hemoglobin level after 1 month of taking prescribed iron. Upon questioning, patient admitted that she stopped taking the iron because it caused stomach pain and constipation. Or patient has age-related dementia and forgot to take her antibiotic as prescribed. Or patient stopped taking her tamoxifen because she cannot afford the medication. ICD-9 provided a single code for tobacco abuse and dependence without differentiation and without further specificity for the type of tobacco product. ICD-10 provides separate codes for these. If your intended diagnosis is dependence, dependence is what you should document rather than abuse. According to the Centers for Disease Control and Prevention, most smokers are dependent, and nicotine dependence is the most common form of dependence in the U.S. Additionally, further specificity is provided in ICD-10 for the type of tobacco product dependence, as cigarettes, chewing tobacco, or other, for example, cigars, so this should be documented as well. Your documentation should differentiate between current abuse or dependence versus a person who no longer uses tobacco. Starting in 2002, the number of former smokers has exceeded the number of current smokers. For tobacco dependence, ICD-10 provides the ability to report remission and withdrawal. Examples of nicotine withdrawal symptoms include irritability, anxiety, difficulty concentrating, and increased appetite. ICD-10 also provides the ability to show a cause and effect relationship between tobacco dependence and nicotine-induced disorders when documented. Finally, your notes for a patient's exposure to secondhand smoke can be converted to an ICD-10 code that says exactly that. In ICD-9, codes for complications did not identify when the complication occurred, the body system affected, or type of surgery performed. ICD-10 codes do. In order to code a complication, the coder must know whether the complication occurred intraoperatively or postoperatively, so include these details in your notes when it is not readily apparent. Additional elements needed for code assignment, which the coder should be able to determine from the record, are body system of organ affected and body system on which the procedure was performed. For example, during right hip replacement surgery, a patient experienced a periprosthetic fracture of the right femur. As seen here, code M96.661 is assigned. We'll take a look at a few procedures that may be performed to give you some exposure to ICD-10 PCS codes and associated documentation requirements. ICD-10 PCS has specific definitions for these two different procedures. A code for excision is used only when a portion or part of an organ or body part is taken. Resection is taking all of a body part. This can be particularly problematic for the coder when your documentation is not precise or ambiguous. For example, the surgical removal of lymph nodes. Resection is assigned when an entire lymphatic chain is removed. Excision is assigned when several lymph nodes are removed, but not the entire chain. So document precisely what or how much of an organ or body part is removed. You don't have to use the words excision and resection according to coding definitions. The coder will apply the definitions based on your documentation of what and how much was surgically removed. Take, for example, open removal of some adjacent disc material. Since only a portion of the disc was removed, a code for excision will be assigned. Here you see the table the coder will use to construct the code for this procedure. The first 3 digits of the code come from here, indicating an excision procedure involving the lower joints. The next digit of the code captures the specific body part, and in this case, the lumbar vertebral disc. The approach was stated as open. No device indicates a device was not left in the body. Finally, without a statement by you of biopsy or indication the procedure was performed for diagnostic purposes, the coder will select Z, no qualifier. The resulting code generated by the coder based on the documentation is 0SB20ZZ. The coding of spinal fusion procedures is very problematic for coders. Documentation of these procedures is sometimes inconsistent and incomplete from a coding perspective. You should precisely document the level of the spinal column involved and the number of vertebral joints fused, such as L1 to L2 and L2 to L3. The approach and devices used to accomplish the fusion, and whether it is anterior or posterior approach, and whether the procedure is performed on the anterior or posterior column. Here you see the table the coder will use to construct a code for our lumbar spinal fusion. For example, fusion of one lumbar vertebral joint via an open approach using autologous bone graft via posterior approach. Posterior column is coded as 0SG0071. ICD-10 coding of fracture treatment doesn't necessarily require additional documentation from you, since you would typically document all elements needed to determine the ICD-10 code. These elements are bone involved, laterality, approach, and type of fixation device, if any. If an external fixation device is applied, additional elements of documentation would be monoplanar, ring, or hybrid. Here is the table the coder will use to construct a code for fracture reduction of some of the lower bones. Note that the ICD-10 uses the terminology of reposition instead of reduction to describe this procedure. You won't have to change your vocabulary. The coder will know that the fracture reduction procedures are classified to the ICD-10 term reposition. For example, the code for closed reduction with percutaneous internal fixation of a right femoral neck fracture is 0QS634Z. ICD-10 requires more detailed descriptions in your documentation of anatomical site and aspects of a disease, condition, procedure, and circumstances of patient encounters. The information generated from ICD-10 codes will result in a more accurate picture of your patients, their severity of illness, risk of mortality, and the services rendered. This in turn will result in
accurate public reporting on quality and outcomes. Should you have questions about documentation for a particular diagnosis or procedure, your hospital's Clinical Documentation Improvement Specialist should be your first stop. The coding staff in your Health Information Management Department is a valuable resource as well. Thanks for joining me, and have a great day.